Good morning, everybody. It's wonderful to be here to talk about the pulmonary aspects of Myhre syndrome. I am Bernard Cannan. I'm from Massachusetts General Hospital for Children in Boston, and it's wonderful to take care of your patients. Now, Myhre syndrome is well known to everybody here, but it has consequences for many different systems in the body. We know that it's a mutation in SMAD4, which results in increased activity. So we call this gain of function mutation. Now we know that SMAD4 is important in the cell. So it controls the cellular signaling mechanisms. And here it is, with a receptor on the top. We have a lot of various SMADs, and then SMAD4 is very important to make the signal to go into the nucleus. So you make new proteins. What happens is if you have a mutation in SMAD4 that leads to Myhre syndrome. Well, you know this because it leads to increased scarring. You see short bones, you see contractures, and indeed contractures are variations of scarring to a degree. These are the main ones that affect the lungs. Now, starting from the top down, there are a number of places Myhre syndrome can impact the airways. The first one is you get narrowing of the airways, the large airways. Now we see what happens is the airways come in like this, and normally it's a smooth tube going down like this, and then you see a branch going here, and this would be to the right, and there'd be a branch going here. And you can see a narrowing here, and a narrowing here that includes all this lung. Now, there are a number of case reports in the literature, and one in particularly well referenced is the one from the Mayo Clinic. This here is probably similar to the mechanisms of Myhre syndrome that you know already. It's probably due to increased scarring of the airways. So if you got an injury in the airway, you ultimately end up getting scarring. Now, it is very hard to treat because what happens is you have to cut the airway with laser, and that in itself is injuring the airway and can lead to further scarring, but it's still the mechanism of action. Now, having said that, it is very uncommon, but it does occur in some patients with Myhre syndrome. Now, it is very easy to see. Now, everyone thinks that you have to do pulmonary function test. You have to do CAT scans or bronchoscopies where you look at the airways to see it. It's easily seen on pulmonary function testing. And usually the patient presents with shortness of breath, significant shortness of breath, or noisy breathing before this happens. So the patient will say they're short of breath going upstairs, or have loud breathing where they breathe noisy, both inspiration and expiration. Now we do pulmonary function test, and it's just a relatively normal pulmonary function test. And to see how it's relatively normal here, and it becomes square. This is called squaring of pulmonary function test. And this is a kid getting airway stenosis over time. So you can see a gradual increase. And now you also see it, you get it, and then there's dilation. So very, very important to see. Very, very important to see. Now, the other form of lung disease that you see all the time, and we talk about it all the time, is restrictive lung disease. This is a very confusing concept for most of us. Now, for restrictive lung disease just means the lungs are smaller. Okay, they're just smaller. Now, smaller means that you take in or blow out a below average amount of air. Now, this is a patient with Myhre syndrome here. And what you can see here is this is a thing called, this is all the air that you can blow out of your lungs. And in this patient, you can see it's 58% protected. Now, FEV1 means how much air you can blow out of your lungs in 1 second, and you can see it's 62%. So what you're seeing is the amount of air that you can breathe out of your lungs is reduced. So that is called restrictive lung disease. Now, there are many reasons to get this. Now, you can get it because the lungs were made small, because in development, you made small lungs. Now, you certainly see this in some populations. The other one that can happen is the rib cage is small, okay? The rib cage is small. Now, the other one that can happen, and also for this, is that you get fibrosis of the lungs and it makes them contract. Now, another way of getting it, which I have not included here, is that the muscles are weak. So if the muscles are weak, you can't blow out the air. So really, many reasons to get obstructive lung disease. The lungs can be small, the cage is small, or there can be something wrong with your lung disease. Now, the lungs can fibrosis. Now, you can also have muscle weakness that can give it. And we see a lot of this in other muscle syndromes, like, for example, Duchenne's muscular dystrophy. Now, this paper from Starr and from many colleagues around the country, including here at Mass General, shows a biopsy of the lungs in somebody with Myhre syndrome. Now, normally these are sacs of air in your lungs that aerate the blood, and it goes into blood vessels that are in the walls of the sac. So oxygen goes into the blood vessels here. So you see it will go in here, go in here, go in here. Now, usually this is very thin-walled, very, very skinny, for the want of a better word. And in this case, it's very thick. This is also from the same patient, from this abstract from this group, and you can see fibrosis. Now, this is the lung, the peel of the lung, for one word, and you can see fibrosis here. So there's just thickening of lung sacs and this fibrosis of the lungs. Now, these are very rare findings. Now, these are very severe when they happen, but very rare findings. Now, the literature, if you review the literature, we can find 2 cases of fibrotic, for the want of better lung, fibrosis of the lungs. One case is the number 2 case from Starr, which is published in the American Journal of Medical Genetics. And then there's a post-mortem study from South Carolina. Now, we have reviewed 25 CT scans and have not seen it from patients with Myhre syndrome. So we've seen episodic descriptions of it, but we have not seen it. Now, CAT scans are routinely performed on children with Myhre syndrome to look at their hearts. So it's very, very easy to see it. So it's easy to screen for. Now, the other aspect of this, and a very important aspect of this, is that there's been, even if you get fibrotic lung disease, there is now new anti-fibrotic agents that are used to treat this and are likely to become mainstay in fibrotic lung disease from many causes, including Myhre syndrome. So I'm very optimistic. Even if you develop this disease, there are therapeutic potentials that we have not seen before, and definitely a group worth pursuing. Definitely a group of therapeutics worth pursuing. Now, the other thing I talked to you about was you could have a small rib cage because the ribs are too thick or too short. Now, this is a chest x-ray from somebody with Myhre syndrome, and this is chest x-ray like this. This is the heart in the middle like this, and then here are ribs. Now, this heart looks big. Excuse me. This heart looks big. But it's not big. The lungs are small, and the ribs are very thick. They don't look this thick. They don't look this thick. So you've got thick ribs that are a little short, and which gave you small lungs. So that's a small rib cage. Now, the next way to get it is the lungs are made small. Now, this is from a child with Myhre syndrome, and these lungs are small. You can see all the tissue out here, but these lungs are genuinely small. And it's very hard to define. Now, this could be in kid with Myhre syndrome because it was made small, or number two, the rib cage is just too small, and it's usually the rib cage is too small. Now, overall, restrictive lung disease is common in Myhre syndrome. It is unlikely to be very significant as the lungs have a huge reserve. In the patients that we see with Myhre syndrome, we see that their lung function is about 80% of predicted. Now, you would think that this is a problem, but you have huge lung reserves, and most people will not see any exercise implications of this. True interstitial lung disease, which is the one we worry about, which is called fibrosis throughout the lungs, is very rare, and we have not seen it here. Now we have therapeutic options for this, so it's concerning, but also the future could be quite bright here. Now, sleep. Sleep is the thing I really want to talk a lot about in patients with Myhre syndrome. First and foremost, insomnia and obstructive sleep apnea are the most frequent things that we see. They are the most frequent things to see. Let's talk about insomnia first. Now, what we call sleep cycle. There's a study from England by Humphreys which looked at autism and looked at how long patients with autism sleep. Now they're in the red line here, and you can see autism patients sleep shorter than regular kids. Now this is, but what's even more strange about this is that 50% of patients with autism have normal sleep cycle. That means those who have short sleep cycle, that's how much time you sleep, it's very short. So for example, half the patients with autism and half the patients with Myhre syndrome only need 5 hours sleep at night. And then they're up and fine and seem fine during the day. So it's a very major concern, very major concern. Now, the normal sleep, and this doesn't project very well, but let me just talk it through. The normal kids need a lot of sleep. You and I may only need 7 to 8 hours sleep, but kids of all age groups need significantly more than this. And only in the, which call, like if they're needing 10 to 12 hours sleep, and then you're seeing the kids just sleeping 5 hours, very, very concerning. Now, and the first thing to think about this is very hard to treat. It's very disruptive to families. Now, what happens in most families is you put the kids to bed at 8 o'clock, and then you stay up and get the house ready and then get to bed. And by the time you get to bed, it's 10 o'clock. And if the child is waking at 1 a.m. or 2 or 3 a.m., then that's a problem. It's a real problem. Now, it may be disruptive to the function of the child during the day. And what we mean by this, now disruption to function is not like in adults, where if you and I are sleep deprived, we fall asleep. It's very opposite in kids. In kids, they become very hyperactive. Also, they don't learn as well. So 2 major problems that you're going to see. Now, the treatment is, there are a number of different ways of treating this. Now, we do use weighted blankets a lot because children with autism do better with weighted blankets. Now, this is very important for getting kids to sleep, but rarely for maintaining sleep. Now, when you're trying to maintain sleep, melatonin, maintain sleep for long periods, it really does come down to therapeutic options. And more and more, the standard is to start with melatonin. And if that doesn't work, to go to a medication such as trazodone. Now, this really should be done with a sleep expert, and particularly somebody who is familiar with autism and autism sleep practices, because it's a very specialized area. Now, apnea, excuse me, apnea is a big concern for patients with Myhre syndrome. And this is the picture of somebody with Myhre syndrome. And what you see here is a prominent jaw, and the mid part of the face is small. So that means the tongue is pushed back and the airway is small. Now the airway is small. Now this is very, very important to recognize. So children with Myhre syndrome are very likely, because of the small airway, are very likely to have obstructive sleep apnea. Now, this is very, very important to find this, because this can lead to delays in development and poor learning, and it has to be corrected. If later in life, it is a increased risk of heart disease and stroke. So very important to deal with it up front. Now, when we do, how do we diagnose sleep apnea? We diagnose sleep apnea by looking with a sleep study. Now, what you do is you come into the hospital, and what we measure is the airflow at the patient's nose. And we look for things where there's no flow. This is it here, no flow in blue. And then reduce with no flow, and then partial flow over here. Now, what we do is when we see no flow here in blue or red, we would say that's apnea. And when there's partial flow, we say that's hypopnea. And then the next step we do is we see how many apneas and hypopneas do we have per hour, and we call this obstructive sleep apnea. We call this the AHI, apnea hypopnea index. Now let me go. Now this is a very complicated slide, and I don't want you to focus on it too much, but I do want you to focus on the criteria for obstructive sleep apnea. They call them mild, moderate, and severe. Now, in children, okay, if you have 1 to 5 mild or hypopneas or apnea events per hour, you've got mild. Then 5 to 10, moderate, and greater than 10, severe. Now, adults are different. See how the scoring is higher? 5 to 15, mild. Can you see? And we're going to have a number of adults in this room. See how it's classified differently. So it's much more serious in children, and mainly because it affects learning. Now, when we get somebody with obstructive sleep apnea, we examine them, looking for things that we can fix. Now, when we examine them, we look in their nose, and we look for allergies. We look for cross bites, which we see a lot in Myhre syndrome, because we can fix them with pallet expanders. We look for enlarged adenoids, which we take out, and we look for enlarged tonsils, which we can take out. Now, if we find obstructive sleep apnea in somebody with Myhre syndrome, the first treatment that we do is an adenotonsillectomy. That means taking out the adenoids or tonsils if they're enlarged. Now, there's this study, which looked at obstructive sleep apnea and looked at the effect of removing the adenoids and tonsils. And 82% of children had a resolution of OSA. And they used criteria of less than 5. So we would say a resolution of moderate, which is an excellent result. Now, things are less likely to improve with Myhre syndrome because they have a small mouth as well, but it's still the first treatment that you would do, and it's still likely to be effective. Now, other things that we can do are pallet expanders. Now, pallet expanders have become very important because the mouth is small in Myhre syndrome, and it looks like this. So what you do, all of us are familiar with them, and you click them and you open them and open them. And in selected patients, now this is looking at the apnea-hypopnea index as you expand. And as you can see in various positions, and position 0, that means just put in, the apnea-hypopnea is 12, 2, 8, and then fully expanded 0.4, which is normal. So in very selected patients, this is very, very effective. So if the tonsil and adenoids don't make it better, this is often a move that we take. Now there is another way of doing this. Because of the midfacial hyperplasia, and sometimes the jaw is small, we consider surgery to the airways, and this is called maxillary mandibular distraction. Now it's used in lots of other syndromes other than Myhre syndrome. Now we haven't used it in Myhre syndrome in our case, and we are reluctant to do it at the moment because of the increased risk of scarring. Now, believe it or not, that could work to your benefit in somebody with scarring. With this, it could. What happens in with distraction studies of the face, what happens is you cut them, the jaw, and then you move it forward. Now, with the increased scarring, this actually means this could heal quicker. And what you have to do is expand the jaw more quickly. Now, we could also, you could expand the jaw or you could expand the midface. But on the whole, the surgery is pretty major surgery. We don't do it. We haven't done it for Myhre syndrome. We do it for a lot of other syndromes, but not for Myhre syndrome. Now, this has to be really done by expert or facial maxillary surgeons, and not all have expertise in it, but it's an important option. But you have to take into account the scarring. And now we see this, and what really happened here was we have done it, and we've been part of these studies. 97% and 100% of kids, well, the other way around, 97% to 100% of adults with OSA will cure this procedure. But you do have to be a little reluctant because of the scarring potentials of Myhre syndrome. Now, if all of this doesn't work, we do positive airway pressure, which is known to you as CPAP. And that's for a long discussion, but not for discussion here. And it's very important, and most of you are familiar with it. And we generally use that as a last resort in children with Myhre syndrome because they've got autism and they tend to have facial sensitivities and they really don't like the mask. They really do not last. But we do have procedures for getting them accustomed to it. And again, thank you for allowing me to speak to you today. It's wonderful to be here at the conference, and look forward to meeting you at the conference, and thank you.